Hello. Ma Nakikita ba yung slides? Okay, nice. Ilan kayo dapat? Sabi ni Dr. Rasul, nasa 26 daw? Remind na lang doon sa other clerks and interns. Join na lang sila. Anyway, no need na mag-on cam. Holiday naman. Oo. Hindi naman ako strict. Tsaka, yun, thank you for coming kahit holiday. Wala namang ano. Hindi naman ako nagtitake note ng naka-on cam or hindi. Makinig na lang kayo. May clerks and interns ba na hindi nakakaintindi ng Tagalog? Any foreign, ano? Wala naman. 16, 17, 18, 19, 20. Pwede na yan? Start na lang so we can finish early kasi I think may second lecture pa kayo today. Okay, so for the first part of your lecture today, we'll be discussing substance use disorders. Very important group of disorders because they're very highly comorbid with mood disorders, anxiety, psychotic disorders, etc. No? So usually we find this along with other psych conditions. So here are the references for this presentation. As usual, si Kaplan, DSM-5. So for the substance use disorders, for you to better understand, the symptoms can be subdivided into four subcategories, such as impaired control, social impairment, risky use, and the pharmacological criteria. Later on, if you will notice, no, as we go on through the presentation, that the symptoms and the criteria will never change. Only the substance will. Halimbawa, you just plug in the name of the substance, halimbawa, alcohol use disorder, stimulant use disorder, etc. Parehas lang siya. No? So we have 11 symptoms under substance use disorder, and you have to fulfill 2 out of 11 in the span of 12 months for you to meet the criteria. So here are the specific symptoms under the four subcategories. So for impaired control, you have these, no? So taking in the substance for larger amounts or for longer than intended. There has to be a persistent desire to cut down or regulate the use, pero hindi nila nagagawa yun. Desire lang. Number 3, a great deal of time obtaining or using substance or recovering from its effects and cravings. So, apat, no, under impaired control. Next, we have social impairment, 5, 6, and 7. So here we see the impairments in the functioning in other spheres of everyday life, such as failure to fulfill major obligations at work, school, or home, continued use despite persistent or recurrent social or interpersonal problems due to the substance, and the individuals miss important social, occupational, and recreational activities because of the substance use. And for the third subcategory, we have two. So recurrent substance use in physically hazardous situations. Number 9, continued use despite knowledge of the problems that the substance cause. So the patients know, no, na may problema na. But then again, as I mentioned, they can't stop using the substance. And lastly, we have two pharmacological criteria, 10 and 11. Very simple lang. Tolerance and withdrawal. Yan. Sa DSM-5, you also have severity and specifiers. So as I mentioned, you have to fulfill 2 out of the 11 criteria I mentioned to qualify for a diagnosis of substance use disorder. For mild na substance use disorder, you have to have 2 to 3, moderate is 4 to 5, and severe if you have 6 or more. We can also qualify where the patient is in terms of treatment. So is the patient in early remission, in sustained remission, on maintenance therapy, or admitted at our center in a controlled environment or sa mga rehab facilities. No? Over time, these severities do not stay the same, no, because they relapse and remit. So the severity of the substance use disorders may fluctuate over time. So for the first family of substance disorders, we have alcohol. So under alcohol, we have the use, intoxication, withdrawal, alcohol-induced mental disorders, and other unspecified alcohol-related disorders. So as I mentioned a while ago, you will be observing and noticing a pattern in the DSM criteria. These are the same 11 criteria that I mentioned a while ago, divided into four categories. No, so yung um, yung nagkakaiba lang, the difference would be yung name ng substance kung ano yung may disorder. So again, no, so you take the alcohol in larger amounts, number one. Number two, the patient desires or has unsuccessful efforts to cut down on the use. A great deal of time is spent, etc. So you will see a pattern na lang. Repetitive ito throughout the other substances. However, what's important here are the other alcohol-related disorders like withdrawal, intoxication, etc. So ito, no? So for alcohol intoxication, according to the DSM-5, of course, the primary diagnostic criteria would be a recent ingestion of alcohol. Because in simple terms, lasing lang naman si patient. So alcohol intoxication ito. And as you know, and majority of you would have experienced firsthand, ang mga symptoms nito ay slurred speech, incoordination, unsteady gait, and in more severe cases of alcohol intoxication, nystagmus, impairment in attention or memory, or coma. No? And usually, the latter criteria in the DSM-5 are exclusion criteria. Just stating simply that the symptoms I mentioned a while ago are not attributable or due to other causes. No, yung slurred speech, incoordination, and steady gait, yun pala na stroke yung patient. No? Pag may ganun siyang history, hindi muna tayo mag-consider ng lasing siya. No? Baka kasi na stroke siya, may residuals. Ganun. Okay. So, this is a fairly high yield, I think, na table, no, ng blood alcohol levels. I think especially sa inyo, no, because you will be taking the boards in a few years or next year or after your internship. Eto, no. So important to remember the cutoff levels of alcohol in the body and the likely impairment that you will be experiencing. So tandaan nyo na lang yung mga dulo siguro sa kayong gitna, no? 20 to 30, nag-uumpisa ng medyo slowed yung motor performance, and on the other extreme end, pag 300 plus na yung alcohol levels mo, mamatay ka na. Yun lang. Impaired vital signs. So on the other end of the spectrum, after ng intoxication, withdrawal naman. So for us to classify a withdrawal, the primary criteria or criterion A must be there has to be a cessation or reduction in alcohol use. That is, yung keywords here are heavy and prolonged. So halimbawa, kung occasional drinker ka lang, nyari, once a week, twice a month, ganyan, hindi ka mag-withdrawal. Hindi naman heavy yun eh. O, pag may ganap lang, saka ka lang iinom, pag lalabas kayo after ng duty, hindi ka naman mag-withdrawal doon. And then, for the physiological symptoms, no, or behavioral symptoms, after cessation in alcohol use, ito yung mga associated symptoms, no. So, there are 8 of them. So, autonomic hyperactivity, increased tremors, insomnia, nausea, vomiting, transient visual, tactile, or auditory hallucinations or illusions, which we see sa ER natin. May mga alcohol doon na psychosis dahil sa alcohol use. Psychomotor agitation, anxiety, and seizures. No? And then the signs and symptoms, of course, for it to be a disorder, itong criterion C, if you can see here, dapat it causes clinically significant distress. Kasi kung di naman siya nakaka-affect sa everyday life, hindi siya sakit. Wala lang, lasing lang talaga siya. Yun lang. So for alcohol withdrawal, this is the general timeline that we follow, no, chronologically after cessation or reduction in use in alcohol. Usually, the most common would always be tremulousness, no? Personal experience as well sa ER natin. 6 to 8 hours after last use, no? Jittery sila, shaking. If you ask them to stretch out their arms, you would observe the hands. Kahit nga hindi pala ipa-stretch out, kausap mo lang, nanginginig na yung kamay niya. No? We also see psychotic and perceptual symptoms 8 to 12 hours after the last use. Half a day to more than 1 day onwards, nagsi-seizure yan sila. So, alcohol withdrawal seizures ang tawag doon. Uh, delirium tremens within the first 72 hours. Nakikita din natin yan. Although, as I mentioned, this is only a general timeline or a common chronological presentation. Minsan, nagsiskip-skip yan. No? So, the symptom of withdrawal sometimes skips the usual progression. And for example, bigla na lang siya mag-delirium tremens. So, something to watch out for. So, as I mentioned, no, one of the latter symptoms pag malala yung withdrawal would be seizures. So, seizures associated with alcohol withdrawal are stereotype generalized tonic-clonic yan. So, how do we detoxify the patient? Wala, magpahinga ka lang. Rest, nutrition, B1, vitamin B1, thiamine. We also use depressants such as barbiturates and benzodiazepines for moderate to severe withdrawal. At our case, sa mental, sa NCMH, we can refer a patient we are suspecting to be undergoing withdrawal to our in-house toxicologist. No, usually yan, nagbibigay na ng diazepam yan for agitation. No? Withdrawal can be mild to severe, and we can also have cases of protracted withdrawal. Sa madaling sabi, the withdrawal would take on longer periods of time. Minsan 2 to 3 months after the acute withdrawal, may symptoms pa din sila. And for those cases, we can use the drug of choice, acamprosate. For us to also better qualify, no, yung alcohol withdrawal, since it's a life-threatening condition, a possibly life-threatening condition, we can also use the CIWA scale. No? Search nyo na lang online yung CIWA scale, CIWA, no, for you to better objectively, no, have a grading of how severe the withdrawal symptoms are. So medications for treatment, disulfiram, naltrexone, and acamprosate, no, as I mentioned a while ago. Out of all these three, we have naltrexone lang available at our center, no, for us to discourage the use of alcohol. So for long-term effects of alcohol, so we have alcohol-induced persisting dementia, or Wernicke encephalopathy, or alcoholic encephalopathy, with a triad of ataxia, ophthalmoplegia, and altered mental status. Yun. Kapag mas chronic ka nang gumagamit talaga ng alcohol, you can have Wernicke-Korsakoff syndrome naman. So, yun lang siya, no, for alcohol. So, we're gonna be moving on to the next family of substances, stimulants. No? So, maraming klase ng stimulants, no? Shabu, yan, coffee, kasama yan dito lahat, amphetamines, methamphetamines, etc. And usual, no, ito na naman yung template of the substance use disorders. So may stimulant use disorders, intoxication, withdrawal, and other specified stimulant-related disorders. Okay. So for stimulants, we have, yun, as I mentioned, no, cocaine, pag medyo social ka, no, sa States. Dito, shabu lang yan. No? So amphetamine, mga synthetic, no? In our case, no, methamphetamine, and also methylphenidate, gamot for ADHD. It's also technically derived from amphetamine. Stimulant siya, and is a tightly controlled medication. So how do stimulants work? So they stimulate, kaya nga stimulant, no, dopaminergic neurons in the ventral tegmental area, or the VTA. This increases extracellular dopamine levels in the nucleus accumbens, more commonly known as the reward center of our brain. The dopamine levels further increase in the medial prefrontal cortex and the limbic areas, activating the reward pathway. So, if the patient experiences a surge in dopamine levels due to the substance use, it induces a feel-good response, no, further reinforcing use of the said substance, no, because the patient doesn't want to wants to experience that feeling of high, no, after the substance use. So, cycle na siya. So for stimulant addiction, it can be characterized as a binge crash cycle. No, these individuals have increased saliency for drug cues. So, for example, what are example of drug cues? Like, for example, a time of the day. Yung iba, pag sumahod, automatic yan. Cue na yan para gumamit siya. No? We have patients like that. Pag katapusan, automatic yan. Gagamit yan with friends. Due to the addiction, no, the impulse control that is exhibit or exerted by the frontal cortex, nawawala na yon. No? So, naging ibabaw yung feelings of pleasure and the reward pathway. So, dopamine and glutamate critically mediate the reinforcing effects of stimulus. No? These are the primary neurotransmitters involved here. Dopamine, yun nga, yung pleasure na neurotransmitter. And glutamate is the major excitatory neurotransmitter. Kaya high na high yan sila, active na active and stimulated. Repeated exposure to such stimulants can result in sensitization. So masasanay at masasanay yung neurotransmitters nila. Hence, necessitating a higher dose of the said substance to achieve the same effects. Tolerance na yon. So for methamphetamine or stimulant dependence, no, stimulants do not really produce neuroadaptations in the areas mediating somatic and autonomic function. No? And besides, kapag nagiging dependent na yung patient, besides dopamine and glutamate, serotonin is also implicated. No? Abstinence sa stimulants would primarily leads to mood disorders but not physical withdrawal symptoms. But as you would notice later on sa future, sa next few slides, baka kasi may mood disorder na siya, baka pala depressed na yan, kaya siya gumagamit ng substance. No? So very, very highly comorbid kasi yan sila. Nagsi-self-medicate with substances to alleviate yung depressive symptoms nila. So for toxicity, as I mentioned, yung neurotransmitters, dopamine, serotonin, lagi naman, no? So pag tinanong kayo, when in doubt, dopamine, tas serotonin. Pag di nyo alam yung sagot, yun na lang, no? In those in Parkinson's disease, mas mataas yung chance sila mag-develop nun if they have been chronic users of shabu or methamphetamine. And then long-term cocaine abuse has been associated with changes in the physical changes in the brain, no? Decreased gray matter volume in cortical regions and cerebellum. And this may play a role in behavioral toxicity. How? Well, wala ka lang ang brain matter, so you would not expect yourself to regulate your behaviors. No? Kaya sila nagiging disruptive. Nagkakaroon, there is a lack of top-down control from the frontal cortex. Kasi nga, wala na silang brain. Nakakaliit ng utak siya, literally. So, ito, again, the same template as with alcohol use disorder. It's the same thing, no? Stimulant use disorder. Ipa-plug in mo lang yung name ng substance. It's the same 11 symptoms. 2 out of the 11 symptoms within the span of 1 year. Yun lang, kailangan niyang tandaan. At least 2 of the following occurring within a 12-month period. No? It's still the same 4 subcategories. So for intoxication, no, obviously, criterion A would be a recent use of an amphetamine-type substance, cocaine, or other stimulant such as shabu. And then after the use of the substance, there has to be clinically significant problematic behavioral or psychological changes. No? Changes in sociability, hypervigilance, kasi praning na praning sila. No? Interpersonal sensitivity, anxiety, etc. No? Best seen sa ER. No? Out of all the substances, shabu ang pinaka-common, no? Nakikita sa ER. Sobrang paranoid, no? Nananakit, no? Very acutely psychotic. And then, commonly, besides yung mga psychiatric na symptoms nila, you also have the following physical symptoms under criteria C. No? So, after yung use ng shabu or ng other cocaine or other stimulants, so tachya, bradycardia, dilated pupils, yung BP nila varies, no? Minsan hypertensive, minsan hypo, chills and perspiration, GI symptoms, nausea, vomiting, weight loss, kasi wala silang ganang kumain, no? After use. Psychomotor agitation, no? By that we mean pacing around, di mapakali, lakad ng lakad, balisa, ganyan. And then in more severe cases, coma, confusion, seizures. So if the patient has been taking in large amounts for a long period of time ng stimulant, no, withdrawal symptoms are the following. Konti lang: fatigue, nightmares, insomnia, hypersomnia, increased appetite. Increase na yung appetite, no, kasi hindi na sila nakagamit. No? Bigla na sila makakagana. And then psychomotor retardation or agitation. Yun lang, no? So, hindi kasing lala compared to alcohol withdrawal, no? If you would notice. So, for the treatment, basically the same thing. It's very symptom-based. So, the gold standard for treatment is motivational na therapy, CBT or cognitive behavioral therapy. But in our setting, of course, sa sobrang dami ng pasyente, we cannot simply sit down with the patient for 30 to 45 minutes kasi bukas pa tayo matatapos sa ER or sa outpatient yan. So, usually naman, anyway, the patients who are addicted to methamphetamine, they would present to the ER kasi acutely psychotic and behaviorally disruptive na sila. So, we address the most pressing symptoms. So, kapag, let's say, the patient is highly psychotic, bibigyan mo na ng antipsychotic. No? And besides, our second-generation antipsychotics such as risperidone also has an impulse control element to it. No? So, it would help address yung impulsivity and yung cravings niya for the substance. And it's sedating as well. So, hindi naman siya makakapag-shabu kung tulog siya. No? So for the next substance, marijuana, cannabis. So it's the most widely used illegal drug worldwide and the fourth most used psychoactive substance in the US. So, so the high is characterized by the mild euphoria, relaxation, and perceptual alterations. And we can also observe cognitive and motor impairment while the individual is intoxicated. So for the diagnosis, the same thing again, no? So you just replace stimulant, replace alcohol with cannabis. And same lang siya. So, for cannabis intoxication naman, of course, recent use of cannabis and then significant changes in behavior. You might have experienced this yourself. Di naman tayo nang judge, no? Pero there are 4 symptoms of cannabis intoxication according to the DSM-5. Mapula yung mata, no? Conjunctival injection, may munchies, increased appetite, dry mouth, and tachycardia. Yun lang, 4 lang. So within 2 hours of cannabis use. So pag withdrawal, we don't really see this much unless you have experienced yourself. If you have been using cannabis for heavy and prolonged periods, the person would be expected to develop 3 or more of the following. So irritable, galit, nervous or anxious, difficulty sleeping, changes in appetite, restless, depressed, and at least one of the following physical symptoms: no, abdominal pain, tremors, tremulousness, sweating, fever, chills, or headache. Pero bihira ito. I have not seen this yet. So for cannabis-induced mental disorders, I think after methamphetamine, this is the second most based on personal experience. Wala naman akong hard statistics for this. Pero after shabu, marijuana ang lagi natin nakikita sa ER and the outpatient. For cannabis-induced psychosis, usually this is very florid. Usually very, very paranoid sila as well. And the paranoia also induces anxiety in the patient. So this anxiety and paranoia is the most common adverse effect of moderate cannabis use. And it's correlated with those. So the more cannabis you consume, mas napapraning sila. So for other unspecified cannabis-related disorders, nice to know na lang. No? Depressive symptoms, sleep disorders, cognitive impairments. However, the most important here would be the motivational syndrome. So a motivational syndrome, nice to know, is a condition wherein after long chronic cannabis use, a motivational, wala na silang volition to perform simple chores, magtrabaho. Na lang sila, kain tulog siguro. Physical effects of cannabis use, na-mention na to, redundant naman na. So, redness of eyes, munchies, and for chronic use, syempre, depending on the way you take in cannabis, pwede ka magkalang cancer kung sinusmoke mo siya. Ganyan. Meron na ngayon, uso, vini-vape na siya, inaamin ng mga patients. Parang may oils na lang, tas ilalagay nila sa vape, ganun. Or so they say, ganyan. So for neuropharma, kasama ko pa ba to? Nice to know na lang siguro, no? Pero for you, a brief ano lang, we have cannabinoid receptors in the brain, and yun yung active, no, sa central nervous system natin. These are mostly found sa basal ganglia, hippocampus, and cerebellum. And then for the peak symptoms, no, the euphoria peaks at 30 minutes and lasts for 2 to 4 hours. However, yung cognitive effects niya and motor effects would last to at least, at most, half a day. And smoked cannabis is 2 to 3 times more potent than oral cannabis. Okay, next disorder, tobacco. We don't really view this as disorder, as this is such a common thing, especially dito sa Pilipinas. It's prevalent, it's deadly, but it's often ignored because wala namang nagyoyosi na nagkakabulong, wala namang yosi na napapraning bigla. No, it doesn't cause behavioral symptoms, and it's legal, socially more accepted, no, compared to compared to shabu, no, yung yosi. So for the clinical features, nicotine exerts stimulatory effects. So improve attention, learning, reaction time, problem solving. No, kapag stress daw, ang iba nag-yosi because it lifts mood and decreases tension, and it lessens depressive feelings. So for tobacco use disorder, again, paulit-ulit, same 11 symptoms, just plug in tobacco instead of another substance. No? The same, 2 of the following 11 symptoms within a 12-month period. Tobacco withdrawal. Ito, no, we can also report this, especially in those who have recently quit smoking tobacco. No? So abrupt cessation or abrupt reduction in use would result in the following symptoms within 24 hours. Iba, irritable, anxious, hindi makafocus, increased appetite, restless, depressed, and difficulty sleeping. For the treatment, it's nice to establish a quit date to work towards, no, with the patient. Yung iba cold turkey, nag-stop ng smoking bigla-bigla, no. However, studies show na it's not necessarily better than gradual reduction and cessation of tobacco use. Relapse is usually rapid, so we advise the patients to follow up early. So we have 5 A's or 5 major steps of intervention. We ask, no, to identify and document tobacco use. Ilang stick ba per day? Or ilang kaha per day? We advise the user to quit, and we assess if the patient is willing to make a quit attempt. And if they are, we assist them, syempre. We counsel them and use pharmacotherapy to help them quit. And then we arrange follow-up contact. As I mentioned a while ago, this is very, very prone to early relapse. So the earlier the follow-up, the better, para makamusta natin sila kaagad. Psychosocial therapies, usually CBT. Yun naman lagi ang gold standard when it comes to substance, CBT. We don't really have reseta or tablets for smoking. More of parang nicotine substitute na patches, ganyan. No? And this is very important because out of all psych patients, half of them nagyoyosi yan. Sa bipolar, no, impaired mga impulse control, 70% of them would use tobacco. 90% of those with schizophrenia. And those with other SUDs or substance use disorder, concomitant, nagyoyosi rin yan, malamang. Very important in our setting because diba, na-stimulating ito and it interferes with the chemicals sa ating mga psychotropics. So, if you have the chance, no, sana kung hindi na bumabagyo at makagawa kayo ng discharge bundle ng patient, nasa paunawa ito lagi. No, wag gumamit ng yosi, ng alak because it interferes with the pharmacokinetics of our psych meds. So usually, mga chief complaint niyan sa ER, yosi ng yosi, hindi na po tumatalab yung gamot. Yan. Kahit upos na yosi sa kalsada, pinupulo tapos sinisindihan. Ganyan sila. No? Kasi hindi nila mapigilan yung impulse mag-yosi. Okay. Neuropharmacology, nice to know na lang. It activates the dopaminergic pathway. So again, pag di nyo alam, dopamine ang sagot. Okay. Toxicity, it's fairly rare, no, na magkaroon ka ng nicotine toxicity unless ilang kaha smoke mo all at once, no? But it's a highly toxic alkaloid, and 60 milligrams would cause respiratory paralysis. In low doses, nausea, vomiting, the usual, no, mga vague symptoms. Pero it's rare, hindi ka magkaka-toxicity sa isang box ng Yossi. Okay, yun lang yun. It's a fairly short lecture. May mga tanong ba kayo or gustong linawin? Or mga questions from your previous Zoom na hindi nyo matanong kasi hindi kayo nakakapasok sa mental. Hindi nyo matanong sa residents. Meron ba? Wala. Mga nakalong weekend na sila. Sige na nga. Since maaga naman ito, wait na lang kayo ng... May different link naman, I think, for the lecture at 3 p.m. Yun lang naman. If there are no further questions, thank you guys for your time despite yung holiday. Okay.